Basically, I'm going to talk about pediatric acute otitis media. For us, it's really just something that's treated outside of our practices and then sent to us, and then we try to verify that it was treated and that they had a certain number of events, and then we're deciding if they need ear tubes. But in general, to understand how to treat and what the impact of pediatric acute otitis media is, this is the direction of this talk. So to understand it and how to manage it. So this is kind of strange, but this is my disclosure slide. And basically, I have no disclosures, at least pertaining to this slide. Let's see if that's going to let us do anything. Yeah. So basically, the talk's going to be about the main things that we need to know about acute otitis media to manage it, and that is, what is it, how long does it last, what causes it, and then have our vaccinations, the new vaccinations we've had since most of us have been in practice, things have changed, and then when should we consider ear tubes. Basically, the impact of it is there's a lot of it. So if you're under 5 years of age, you're going to have one of these. There are 5 million cases a year. Okay, and it's often listed as the most common condition that is treated with antibiotics. You just have to do a quick Google search to find out that there's 8 million UTIs, so that's more than 5 million. But in the pediatric population, you can for sure say it's the most commonly treated condition that needs antibiotics. The cost of care is significant, 5 million cases, but 10 million courses of antibiotics. And then most of the cost of care in the past has been somewhere like $200 or $300 an episode. That's your doctor's visit, your antibiotics, maybe a follow-up. But in some recent studies where they've really looked at all of the costs, indirect costs of the parent taking care of the child, it really is a very expensive thing. So we'll see moms that are only on their 3rd or 4th bout of AOM and they're like, yeah, I need tubes now. And it's because they're really deep into this. $1,300 if you actually look at opportunity costs for mom. Yeah, they base this on, I see a crinkle eyebrow there, they base this on income, whether they were employed outside of the home, whether they were not, and they actually assigned values to not doing your dishes because you're holding your crying baby, and they, giant equation on, you would have been reading or having some fun or paying attention to your other children versus, taking care of a sick baby. And we all know that these moms are up all night with these children, so, you get 8 hours, and they actually put a variable in there for sleep and the value of sleep. So that's where you get to $1,300 per episode over the first 3 months after about. So our economic burden is significant. We've got our direct, indirect costs. And then we have the outside of little baby with it, what happens when grandma takes care of the little one, and the cost of pneumonia for grandma. And then, of course, what is the actual cost of antibiotic resistance? And we all know that we're sort of in a breeding ground in regard to creating resistant organisms in our pediatric population. So these are the bigger numbers, which is by age of 3. And now these numbers are based on an old study, and there's some new numbers that are a little bit lower than this, but they were the acute bouts of AOM, or the bouts of AOM were confirmed with tympanocentesis on the new study. So this is based on old data without tympanocentesis confirming your acute otitis media, and we all know that we're not getting tympanocentesis to confirm these, and so we're treating based on clinical findings. So 5 out of 6, by age 3, 5 out of 6 of kids are going to have at least one bout. By age 3, 6% or 1 in 15 are going to need ear tubes. And then the numbers change a little bit. They change significantly for really were these acute otitis media. It drops to 60% if you actually did a tympanocentesis to confirm it. And then it drops, but then the otitis prone goes up a little bit because that whole 23% or so of kids that were misdiagnosed, they're not going to be in the otitis prone. So that's all relative to, the fact that your diagnosis of AOM was so solid, and that's why your otitis prone goes up a little bit. So our talk really is going to be about the definition of acute otitis media, the pathophysiology, the impact of the pneumococcal vaccination, and then treatment will be kind of brief because the treatment is brief. It is pretty straightforward, but we'll go through some of the permutations. And then this is the anatomy we've already reviewed throughout the day: ear canal, tympanic membrane, middle ear space, and really the middle ear space is filled with pus. It is a very painful condition to have, and if you have adults that have this, they are crying. It's really terrible, and so of course the 18-month-old is upset as well. So here's your normal eardrum on the right. You can see your normal landmarks, a translucent eardrum, and this is your really dramatic findings for acute otitis media. It should be dramatic. It should not be sort of subtle. Okay, so our definition for AOM is that it is a 3-week, it's the first 3 weeks of a process. So if you see a kid and they have AOM and you see them 4 days later, you're not going to expect it to have gone away. Okay, this is the first 3 weeks of a process where the acute part of it is what you see on the right here. So acute onset of inflammation in that middle ear space, and there are signs and symptoms of an infection. So if you have a child who comes into your office and their ear looks terrible, but they're fabulous, then they don't have an acute otitis media. They may have an otitis media, but it's not acute, and you're not going to treat it like this. So, you know, I do see parents who come and go, oh, he'll be fine. They'll just diagnose this on his well baby check. They may have an otitis, but if the child is not symptomatic, it's not an AOM. So they have to have a bulging, TM, pain, fever, and the most common age is going to be under 5 years of age, really with peak at 12 months. And the source of it, usually the beginning of it, is usually a viral upper respiratory infection. So the whole pathophysiology is on this slide, if I can get it sort of centered. And basically, we have the bacteria that cause the infection living with us. They live in our nasopharynx. Our nasopharynx has our adenoid there, and it also has our opening of our eustachian tube. So this kind of shows the eustachian tube going up to the middle ear space. And this bacteria is living all in there. They love us. We are actually their natural home. And then we're fine until we get a virus, and then the virus does a couple things. It makes the area more prone to let those, what are just basic colonizers, get in. So it injures the area. Some of the viruses will actually potentiate or trigger the bacteria to become virulent. And then the other thing it does is cause significant inflammation at the eustachian tube opening. Our middle ear space has to be a space. It can't be blocked and filled with fluid, or it'll start to get an infection. So this is sort of the beginning of it. And then, so it sort of looks like this: viral URI, eustachian tube dysfunction. It activates the opportunistic otopathogens, and then you have an AOM. And it looks like I don't need the clicker because I can just slide up. Our risk factors, so this otitis prone thing, on the bottom of that definition slide for AOM, that didn't come up, the otitis prone definition is 3 infections in 6 months or 4 infections in a year. So the risk factors for being otitis prone, you'll see a real long list of what are the risk factors for acute otitis media. But for otitis prone in specific, it is being male, white, white non-Hispanic, and the biggest ones in bold are the family history of recurrent acute otitis media. So if you're in your family, everybody got ear infections and needed ear tubes. If you're in daycare, those are the 2 biggest risk factors for otitis prone. And then it is true that if you get your first acute otitis media really young, it is very hard for them to clear the fluid, and then they're set up for another infection. So early occurrence of first AOM. You will see a longer list of contributors. The contributors in this study, which is the large epidemiologic study that is listed in your pamphlet, these are factors that just increased your chance of having 1 more infection under the age of 3. So being allergic, so atopy, the use of pacifiers and bottle propping. My kids are graduating from high school and stuff, so I had to look up bottle propping. I'll show you a picture of it that's fascinating. And then there's, you know, the smoking parent and other children in the family. Some of these, the little asterisk ones, were may have more contribution than we think, but it was hard because they were so linked with other factors that they couldn't differentiate them. And then it is true that if you breastfeed, you will drop your child's chance of having more acute otitis media than they would have had. But again, it's by one. It's sort of in that strength of the contributors. And then this graph just shows the percent of the first time that you get your acute otitis media by age. So you see that really high bar at 6 to 12 months. So this is the bottle propping thing, and there are all sorts of things you can buy so that you don't actually have to hold your baby and feed it at the same time. And so you prop it up, and I remember thinking, I'm going to prop this, but we didn't have things to buy at that time. So you can prop up things. You see this apparatus for propping the baby's bottle form. And then, of course, you could be doing more important things like taking a selfie while you feed your baby. And then there's a couple other risk factors that they list for, again, being having a few more or one more under 3, not being otitis prone, but just having maybe an additional infection, and that's the craniofacial abnormalities, like cleft palate would be our most likely one, and then GERD and immunodeficiency. So this is just a graphic that shows the difference between the eustachian tube configuration, peds and adult, and this difference really does happen right at that 3 to 5 year mark. You know, you get that elongated, instead of the baby face, you get that little boy face or the little girl face, and that eustachian tube elongates, and then the adenoid, you know, is a bigger play in kids and adults, and then also just the immune stuff that we'll talk about. So this is a picture of a nasopharynx, and it shows the adenoid, and then, you know, your eustachian tube is tucked right in there. Okay, so this is a septum, there's the adenoid, and your eustachian tube is tucked right in there, and you can see all this muck, goop in the back of the nose, and, you know, we call that biofilm, and in the biofilm we're going to have these bugs. So these are our main infection, our otopathogens, so strep pneumoniae, H flu. This is non-typable, so instead of the coded one, we're the non-typable H flu, and then Moraxilla catarrhalis. So, and then there's a picture of our bad guys. So strep, Moraxilla on top, and H flu in the bottom. And then this is sort of what's going on in the back of our noses, and there have been some studies just about like what's happening there, and some of this, there was great concern when they started doing the pneumococcal vaccination trials, is that we have this competitive, so we've got some protective commensal bacteria, the Corynebacteria, Haemophilus hemolyticus, and then we have these competitions that where strep will secrete something that staph doesn't like, and then staph will do something to get the strep gone, and so there's this sort of turf war happening in the back of the nose, and we were concerned that if we gave people pneumococcal vaccinations, that then maybe we'd have more staph infections of the middle ear. And it has turned out that that post pneumococcal vaccination era, so that's the era we're in, that that there hasn't been an impact on Staph aureus colonization rate. So they didn't, you know, staph did not replace the strep. And then these are our biofilm producing otopathogens. So here we are with our 3 top ones in that muck around the adenoid right next to the eustachian tube. So that's sort of the way it kind of gets set up. So I'll kind of run through these quickly because there's a ton of information about the individual bacteria. Pneumococcus, so I always call it pneumococcus instead of strep pneumoniae. So if you hear me interchange, strep pneumoniae is pneumococcus. Pneumococcal vaccination, that's all strep pneumoniae. And it's complicated. I mean, we've been studying this bacteria for years, and we know all this stuff, plus. And we know about all the surface proteins, how it infects, all the different kinds of things it can do. And then we've typed a bunch of different ones out. So there are 46 serogroups, and within those groups there's 92 serotypes. And then the big kicker is that 13 of those serotypes are the cause of 90% of invasive pneumococcal infection. So we talked about the cost of acute otitis media, pediatric AOM, and it's really about invasive pneumococcal infection when we look at our cost, our impact of pediatric AOM. And here's a sweet little grandma who, you know, is over 65 and is at risk for any terrible pneumonia to kill her. And there's the sweetest person she's ever met in her whole life. Who's gonna kill her? This little girl has a big old adenoid with all this biofilm on it, and grandma is at risk for this: meningitis, bacteremia, bone and joint infections. Those are the invasive pneumococcal disease, and then the non-invasive stuff is the stuff we're talking about, acute otitis media, pneumonia that doesn't cause bacteremia. And so, you know, worldwide, pneumococcal infections are still are a leading cause of morbidity, mortality, and it's for this age group, the little one and the old one. In those 13 serotypes that are in our most, and we'll talk about the three vaccinations, these 13 serotypes are the ones that cause, you know, 90% of invasive pneumococcal disease, and the bolded ones are the ones for AOM. So 6A, 6B, 9V, 14, 19A, 19F, and 23F. Those are the infections for AOM. And then there's just some stats on not only are they 90% of disease, but they're also 80 to 90% of antibiotic-resistant strains. So pneumococcal vaccination has really changed the dynamic. We started off with the Prevnar 7. There is a difference between these two vaccinations, the conjugate vaccinations and the polysaccharide vaccinations, that are the answer for why we don't give pneumococcus, pneumovax to little kids. I mean, why don't we give that to them? It's got 23 serotypes. Well, the reason we don't give it to them is for the same reason they have the problem, is they can't mount an immune defense to a polysaccharide. That's why these three pathogens are so likely to cause them acute otitis media, is they can't fight them. Their immune system is not able to recognize that polysaccharide capsule. They don't mount a response to it like adults do. And so these Prevnar, the pneumococcal conjugate vaccinations, take that a polysaccharide capsule and they link it to a protein that the little baby and the little kid can respond to immunologically. So the babies and the little kids are getting Prevnar 13 nowadays, and the vaccination schedule is what they call a 3+1, which is the 3 initial ones, 2, 4, and 6 months, and then a booster. The +1 is the booster at 15 months. Some of the things we're going to talk about in the next slides are that instead of the vaccination making us have more Staph aureus in the back of the nose or have Staph aureus be an infectious thing, instead the pneumococcus is capsule switching. And they literally can switch, transfer genes from one to another to become a non-vaccination type pneumococcus, okay? So capsule switching, where genes from one capsule are exchanged for another through genetic transformation or recombination, and that's how we get this vaccine escape, where pneumococcal infections are escaping the vaccination. So this data here is very cool, I think. Any graph like that, I love that. Big dramatic change in the graph that I can see. So this is the effect of PVC7. So this is the first vaccination that came out in 2000. And overall, so if they just looked at the invasive pneumococcal disease caused by the types of pneumococcus in that virus, they dropped 99%. Huge, huge drop. That's all groups. And then if you looked at the kids and the under 5 and the over 65, they had drops too, but they still were our highest group of people getting invasive pneumococcal disease. If you looked at all types, okay, so all invasive pneumococcal disease, they were 76% down for the under 5-year-old, 37% down for the over 65-year-old. And that's the difference between these two graphs. And I'm sorry, I can't fit it on one screen, but you can see this huge, giant, dramatic drop for the kids and a drop for the over 65 too, but just not as dramatic. And then on here, you see this 19A, and that's part of that capsular switching thing where they started seeing more infections with 19A. Well, now 19A is going to be caught with the Prevnar 13. Okay, so this is just data on Prevnar 7. This was the question that you guys got before the conference today, and this was out of a study, the rates of AOM and bilateral myringotomy and tube placement, that's the BMT. dropped dramatically. This was at a study out of New York, the state of New York. Now, the state of New York got initially started with the 3+1, the 3, 2, 4, and 6 month vaccination, and then the 15-month, and they had these kind of decreases. AOM decreased by 28%, and BMTs decreased by 23%. But again, they did the 3+1 boost, 3+ booster, 3+1, and then this study that these are quoted out of compared them to the state of Tennessee, where they just did 3. They just did the 3+0, no booster. And they did, their rates of AOM and BMT also dropped, but just not as much as they did for the 3+1. So here's sort of a schematic that shows the difference in the otopathogen frequency over time affected by the vaccinations. So you see when in 1995 to 97, we started off with strep pneumo being our most common pathogen, H flu being our next, and then MCAT at the bottom. And then the vaccination is introduced and you see the strep pneumo drop, and you see the H flu go up. When they put the question up, I actually was like, ooh, because I didn't write that question, and I probably wouldn't have put the H flu as that, because I don't know the percentage over, H flu is 60% of infections now, but I don't know what, if you looked at it over time, it'd be hard to say if it had an 80% increase or what. But the answer to that question was about the BMT rate. So here you can see it drop in after the 2000 start of PV7. And then you see it kind of come up, and here's that capsular switching, that 19A coming up, and then you see the Prevnar 13, and it drops again. And this drop, I couldn't find it in the article that this graph was in, and I couldn't find it in subsequent articles, but I think that this latter effect you have here is this accepted now 3+1 with that booster, this additional drop. But this is an arms race. So we can have this capsular switching, and then there are going to be other types that go up, and so this will be something that will probably have to be modified as we go through time with pneumococcus switching around. So off to H flu, it's a gram negative. It is not the H flu that we vaccinate for, because that is type B. All the H flu that say type whatever are encapsulated. It is a non-encapsulated, sort of non-typable, and it now makes up 60% of acute otitis media, and 45% of H flu are non-typeable H flu are resistant to amoxicillin. When they look specifically at the otitis-prone group, so this is a study where they looked at the different otopathogens for not otitis-prone and otitis-prone. And if you look at strep pneumo, the rates are the same. Like, is it the bacteria that makes them otitis-prone, or is it not, right? And for strep pneumo, they're the same. For MCAT, they're the same. I mean, there's a little difference, but those are not significantly different. And then for non-otitis-prone and otitis-prone, you see a difference for the H flu. People who are otitis-prone are more likely to have H flu as their otopathogen. There is a vaccination for non-typeable H flu. We don't use it in our country. There's a bunch of cost analysis comparing it to the Prevnar 13, and there's been a hesitation to adopt it in the States. And some of that is, again, these arguments about how is it going to impact colonization, because one of our friendly bacteria in our nasopharynx is Haemophilus hemolyticus, and we're afraid that that might also drop our Haemophilus hemolyticus and then give us some issues. And then our last otopathogen, Moraxilla catarrhalis, it is also a Diplococcus like pneumococcus, also gram-positive. And I always have these relatives that ask me questions like, well, how come when I get cold, I get sick, And there are some bacteria that are activated through cold exposure. MCAT is one of them. So you can have it live with you normally and then get exposed to cold and have it activate. And so it is cold activated. And then MCAT is also highly resistant to beta-lactam. Okay, so it's a beta-lactam resistant at high rates. And then we have sort of normal carriage rates of MCAT. Healthy adults in the States are about 3%, but you can see there's differences in cultures and in specific genetic types. So, lots of our Native Americans in our country have very bad chronic ear disease. And it might not just be that they don't get treated appropriately. They may really have, like the Australian Aborigines, they may really carry a different flora in their nasopharynx. The otitis conjunctivitis syndrome is the goopy eye and the acute otitis media at the same time. And if it's not viral, it's not like the first day of it, like, a couple days into symptoms, they have the eye and the ear, you're going to go straight to Augmentin. You're not going to do the amoxicillin, high-dose amoxicillin that we're going to talk about in a minute. So the otitis conjunctivitis syndrome is MCAT, and because it's highly resistant, you go to Augmentin. So here we are with our medical management, and our diagnostics are down here, really. So it's this picture plus fever and a couple days of it. So, you'll have the kid who just got sick last night, and he's got 102 fever in your office, and of course his eardrum's red, his whole face is red. And so it's a little bit early to diagnose an acute otitis media that's bacterial. We really do want it to be sort of a 48-hour thing, or you're going to be treating a lot of viral otitis. But if you got this red bulging TM, painful fever, and it's been a couple days, or if you just have this otorrhea that, the symptoms were preceding and then they got this big bloody pussy drainage, you're going to make that diagnosis. And the medical management is going to be first and foremost pain relief. You're going to have them on ibuprofen, acetaminophen, or a combination of the two. You can do the topical drops. Abiotic or Oralgan is usually benzocaine and antipyrine, which is an NSAID, and they work. You have to be very careful. We tell people once they have ear tubes, throw away the abiotic, because that really will burn your middle ear in a kid who's had ear tubes. So if you use a lot of topical, that's fine. It'll work. But really, ibuprofen, acetaminophen, and the abiotic would be in addition. And then if they're under 2, you are going to give them first line high-dose amoxicillin, and it's going to be 80-90 mg per kg, divided twice a day, and it's a 10-day course. The difference between under 2 and over 2 is going to be the length of that high-dose amoxicillin. So if they're under 2, you're doing 10 days. If they're over 2, you're going to go for 5 to 7 days on that first treatment, which is going to be high-dose amoxicillin. Anyone you diagnose and treat for an acute otitis media, you're going to schedule a follow-up, because that's part of your treatment. You're going to see them 48 to 72 hours later and see if they've improved. Their physical examination might not look a lot different, but they should be less febrile, they should be in less pain, and just generally be heading in the right direction. They don't have to look like it's gone, because again, we don't expect it to be gone for 3 weeks. So that they're better. If they're not better, then you're going to Augmentin. That's going to be 90 mg per kg based on the amoxicillin component. And for the under 2, it's going to be 10 days. For the over 2, it's going to be 5 to 7 days. That's really the only difference between under and over 2 is the length of the antibiotic. Okay. The other component to the over 2 that you'll see in the literature, and it is sort of a battle, and that is some people say we shouldn't give antibiotic at all for the over 2. Now, this is not an argument for under 2. This is only for 2 and older, that you should just do pain relief, see them back in 48 to 72 hours, and only start an antibiotic if they aren't doing better. And again, that's sort of a personal preference. I have a practice preference. I have patients that will come to me mainly because their pediatrician is unwilling to not give the antibiotic, and they want the ear managed without any antibiotic. And so I have a number of, they're generally usually European, people who are from France living in Arizona, or they're just opposed to antibiotics. And for the under 2-year-old, it's not a discussion. You have to treat that child. But if they're over 2 and the parent doesn't want the antibiotic, and again, this is the rare case. Usually you're like, you really don't need the antibiotic. But for the one who doesn't want the antibiotic over 2, they don't have to use it. But you are going to see them back 48, 72 hours after you start any treatment, or if you don't start treatment, you just do pain management, you're going to see them back to see if they're responding. And then we would say, well, why on earth would you pick high-dose amoxicillin? You just told me that MCAT's resistant, H-flu's resistant, and strep pneumo's resistant. And this would be the reason why we say to still use high-dose amoxicillin. Your cure rate, even with all that data about resistance, is 57% for high-dose amoxicillin. Of course, it's higher with Augmentin, but there is well-accepted data out there that says there's actually a spontaneous cure. Like these things, even when they've been proven by tympanocentesis and the bacteria have actually been identified, that they can spontaneously resolve. And those spontaneous resolution rates are 20% for strep pneumo, 50 for H flu, and 80% for MCAT. So MCAT's really resistant, but like it might just spontaneously resolve. So, and then we have our high overdiagnosis rate. I mean, like we all know this screaming kid and they've got stuff in their ear and you can't even see anything. And you're supposed to make a diagnosis of something that relies on a good exam of the tympanic membrane. So we have our overdiagnosis rate, we have our spontaneous cure, and then we have all the adverse reactions to augmentin, to the clavulanate. So you can, by guideline, write for high dose amoxicillin, see them 2 to 3 days later, and if you have to switch, then you switch. Okay. There's another caveat to medical management, and that's a younger age group. These are just some pictures of different ways that acute otitis media presents. You might see that big bulgy red eardrum on the first day you treated them. When you see them back 48 to 72 hours, they may look like this, but it's an improvement. It's not as red, it's not as bulgy. So for the neonates, neonatal acute otitis media, usually those bacteria are related to the birthing process. They're usually bacteria they pick up through the birth canal, and you're going to have group B strep, gram-negative enteric bacteria, chlamydia. Those are going to be your pathogens for an acute otitis media for a newborn. And so if they're under 2 weeks with the immune system that they don't have, and then this bacteria that may be more troublesome and more likely to give them a full septic situation or a meningitis, that little neonate needs to go to the hospital. They need to go get a full sepsis workup and be treated. That is a very serious condition. A neonate sick with an acute otitis media, high fever, all of those signs, they need to go to the hospital. If they are over 2 weeks, you can treat them. They're full gestational age. They're not like corrected age or whatever. So they're not a preemie. They're really a full over 2 week old newborn. You can do the regular treatment. So high dose amoxicillin. For the panallergic people, amoxicillin allergic, unless they have urticaria or anaphylaxis to amoxicillin or penicillin, you can do the cephalosporins, okay? So even though there's a bit of a cross-reactive rate, it's low, under 5%, and again, if they don't have urticaria and they don't have anaphylaxis with that penicillin, then you can go to ceftonir or cefuroxime. And then there is a lot of good data on azithromax, and the treatment courses are interesting. So, we all know there's a 5-day, and then there's a 3-day, and there's a 1-day. And so I have kids that either they're in charge of the family and so they're not taking any antibiotics, or they're autistic and they're not taking any antibiotics, or lots of reasons why they are not going to comply with the full course. And you can do 1 dose, 30 mg per kg, 1 dose of azithromax. Don't tell anybody because Zithromax has a high, like when it first came on the market, everybody used it and then we had resistant rates right away. So save this in your back pocket, don't tell anybody. But you can do a 1 dose for Zithromax. And then if you run through that whole protocol, you saw them, they were over 2, you just gave them pain medication, you saw them 2 to 3 days later, they still looked bad, they didn't look like they got better at all, you started the amoxicillin, you saw them 2 to 3 days later and they still weren't good, and you went to augmentin, and then you saw them 2 to 3 days later and they're still terrible, you're going to Rocephin. Clindamycin's really poorly tolerated in kids. I would just go to Rocephin. And then depending on, how bad that kid is at that time, you're probably going to do, you're going to decide between 1 and 3 days of that. So that's sort of how it runs. You're going to treat, see them 2 to 3 days later, treat, and then you're going to escalate until they actually start to respond. And then again, just some more pictures of what it can look like. And then here, of course, is the perforated drum. You're not going to see this little perforation because there's going to be pus all in there. This is someone that they suctioned all the gunk out, and you can see the little perforation under there. Again, the otitis conjunctivitis syndrome with MCAT, you're going to go to augmentin. And then when is it a new AOM? So if you treat them and you finally see them 2 to 3 days later, they're finally better and they go about their way, and then they return and it's been under a month, then that's the same episode, and you stay on your pathway. So you already did amoxicillin, they seem to get better, they come back a week later, you're going to augmentin. Okay. If it's over a month, then you start all over again. Pain relief, if they're over 2, maybe nothing else. If you want to, amoxicillin, and then you just start your pathway again. Okay. For surgical management, this is the first procedure that we learn how to do in ENT. We do a lot of them, and they are really, really very helpful. Parents will tell you that they have their life back because they can sleep again. And it is only for the otitis prone. So it's greater than 3 bouts in 6 months, greater than or equal to 3 bouts in 6 months, or 4 or more in 12 months. And then they should be referred. We are going to do our job when you send them to us, and we're going to actually follow our guidelines. These are some pictures of water precautions, and this is a Ruder bobbin titanium tube, and that's a T-tube. So there's a couple different kinds of tubes we place, but the one up here is the most common, this shape, but in white or blue. And our guidelines say that when your referring doctor sends you a child who's otitis prone, by the definition we've stated, that you should not put tubes in if they don't have effusions when you see them. Most everyone will have effusions, at least in one ear. So they have to have an effusion at least in one ear when we see them. That doesn't mean they're actively infected when we see them. It just means that we can show that they have eustachian tube dysfunction. They never clear the fluid, which is the whole idea that they are otitis prone because they don't clear the fluid. On occasion, you will have someone who does clear fluid in that 2 to 3 week mark. And so for some of those, I actually see them during the time of infection confirm that they really are recurrent, acute, and that they don't have signs in between. So I do write the letter, hey, yes, you sent them at the right time, and I believe you that they have this, but I have this thing where their temps are normal right now. So either they're done with this and they're just going to fly and we don't need it, we're at the tail end of this problem for them, or I'm going to see them when they're sick next time and confirm it and go put tubes in. And then from the pediatric, it's just that tympanostomies are an option. We would say that that without tubes, we would go back to when in our residencies we did 300 mastoids. When I went through residency, I did 3. That's why I had to go do an ear fellowship to be able to do a mastoid without any problem. And before we had tubes, we really did have a lot of chronic ear disease. We had 10 Dr. Fucci's instead of 1 Dr. Fucci in a metropolitan area like this. Okay, so if the tubes are an option, and of course we would strongly say, hey, do it. 1, did not have the antibiotics for the kids, and 2, not to have those chronic hearing loss, giant perforation, some of the pictures that you just saw, cholesteatoma, all that stuff is untreated otitis in children, or not appropriately managed otitis in children. The last thing that our academy says in our latest guidelines is once they have tubes, you don't have to have mom chasing them around the baby pool with earplugs. They really can go underwater in clean water. That's chlorinated pools or saltwater pools or the ocean. And then as long as they're not going deep. And if you're putting tubes in the age group that needs them, which is under 5, most of those kids are not going that deep. Okay, some special precautions for dirty water. Every river or lake in Arizona I would consider dirty, very dirty. So if they're going to go up to the lake and they're going to be in the water, I usually have them wear plugs for that. Some kids will just complain that it hurts their ears when they go underwater, and just put plugs in those kids. You don't need it for prevention of an infection, but they can feel the water come in, and maybe that hasn't built up enough pressure to get through that 1 millimeter opening in the tube, but it's enough to bug them. And so for the kids that it bugs them post tubes to go underwater, just put precautions on them. And then if they get an ear infection post tubes, the treatment is topical. It is not back through that whole amoxicillin augmentin thing. We don't have to do that anymore. We can put the drops right in their ear. They don't have to systemically absorb it. We know right away when they're infected because they just start to drain out that ear. Sometimes it's so thick we need to have parents take a little blue bulb and suction that gunk out so the drops get in. That's the most common thing I'll see where kids are on drops and it's not getting better. And it's just because it's not getting in there. So topical for post-tube otorrhea, and that is it. So we've got a 3-week illness, strep, pneumo, MCAT, H flu, and Prevnar has decreased both rates of AOM and invasive pneumococcal disease, and that ear tubes should be considered for otitis prone. And that's that. Any questions for me? Sorry for my technical difficulties.